Hey guys, it's Medicosis Perfectionalis one more time. We're talking about acute phase reactants. We have talked about ESR before, a garbage test. Today let's talk about C-reactive protein or CRP, a less trashy test. So let's get started. In case you are living under a rock, I'm doing rheumatology videos mostly every Saturday. I'm also doing bleeding and coagulation and fluids, electrolytes, and acid-base disturbance. That's why you should subscribe and save this rheumatology playlist. When we talk about C-reactive protein, we'll start with the definition, the mechanism, the normal plasma level of C-reactive protein, the aim of the test. Does it have a diagnostic value? I doubt, therefore I am. Prognostic value, and last thing, a comparison between CRP and ESR. Please don't confuse CRP with CPR. This is C-reactive protein. CPR is cardiopulmonary resuscitation. One has nothing to do with the other. C-reactive protein. It's a protein. No kidding, because everything that's active in your body is protein. Have you ever met an active carbohydrate? Never. How about an active lipid? Doesn't happen. The active thing in your body is always protein. It's protein synthesized where? In the liver. Shocker, isn't it? And it's synthesized in response to interleukin-6. So you have cancer or you have inflammation, they secrete interleukin-6. Interleukin-6 goes to the liver to stimulate the liver to secrete a C-reactive protein in response to inflammation. That's why we call C-reactive protein an acute phase reactant, something that happens when there is an acute process such as inflammation going on. Also, interleukin-6 will stimulate the liver to produce TPO, thrombopoietin, leading to increased number of platelets. We call this process secondary thrombocytosis. Also, inflammation can raise the ESR. So in acute inflammation, you will have high ESR and high C-reactive protein at the same time. We have talked about acute phase reactants in the previous videos. They are proteins secreted by the liver. Their plasma level increase in cases of inflammation and decrease when there is no inflammation or when you cure the previous inflammation. During inflammation, as you know, you have the cardinal signs of inflammation. You have fever, you have leukocytosis, you have interleukins, because interleukins are the internet of the leukocytes, and IN just means protein, and S is just for plural, it's called English. And interleukins go to the liver secretes acute phase reactants. So acute phase reactants can promote sepsis. Yeah, it's inflammation, very likely. The cardinal signs of inflammation, as you know, redness, hotness, swelling, pain, loss of function. Rupor, dolor, tumor, calor, functulus. I love Latin, that's why the name of my channel is Medicosis Perfectionalis, where medicine just makes perfect sense. Why do we call it CRP? Why not FRP or DRP? Okay, because it was first discovered in the plasma of a patient with pneumonia. And as you know, pneumonia is an inflammation. And since it's inflammation, it makes sense that CRP is an acute phase reactant. It increases when you have inflammation. Because when you have inflammation, we add the suffix itis to everything. You have pancreatitis, you have otitis, urethritis, etc. But we don't say pneumonitis. It's kind of heavy on your tongue, so we say pneumonia. And this CRP reacted with the C polysaccharide in the capsule of the ugly Streptococcus pneumoniae. Remember the Quilling reaction? Quilling is just German for swelling. So this CRP reacted with the C polysaccharide in the capsule of this bacteria, so we called it CRP. I'm not kidding. And I'm pretty sure your professor didn't tell you that. So the pathogenesis goes like this. We start with a bacteria or a dying cell. They lead to inflammation, because if inflammation is not gonna happen because of bacteria or necrosis, when it's ever gonna happen? Then, if it's inflammation, we'll start with white blood cells. If it's cancer, we start with cancer cells. If you are morbidly obese with diabetes and increased risk of cardiovascular disease, it's the adipocytes. All of them will secrete interleukin-6. It goes to the liver. The liver will secrete C-reactive protein, but the C-reactive protein needs a receptor. Like any molecule in your body, to exert an action, it needs a receptor. The receptor here is called the phosphocholine receptor. It's on the bacteria, it's on the necrotic cell. Cool. Then once the receptor is attached to the ligand, in this case the C-reactive protein, the macrophage is stimulated. It's gonna eat the bacteria or the dying cell, activating the complement C1q, which is in the classical complement pathway, leading to the activation of the MAC. When there is MAC, there is attack. Go to hell, bacteria. And that's, my friends, how we kill these suckers. See, C-reactive protein is kinda cool. What's the normal blood value? 0.8 to 3 milligrams per liter, not per deciliter or milliliters, per liter. Do we ever care about low CRP? No. Do we care about high CRP? We could. ESR and CRP, acute phase reactants, markers of inflammation. When inflammation occurs, they increase in value in the serum. But they are not specific. It could be bronchitis, otitis, pneumonia, pleurisy, hepatitis, pancreatitis, cystitis, pyelonephritis, gastroenteritis, meningitis, rheumatoid arthritis, systemic lupus erythematosus, Sjogren syndrome, and scleroderma, and others. They correlate with disease activity, which means if you have rheumatoid arthritis and your ESR is 130, let's say your CRP, the normal value is like less than 3, it's, I don't know, let's call it 60. It means that there is lots of disease activity going on. They correlate with the response to therapy. If you're taking medications for rheumatoid arthritis, your ESR decreased from 130 to 30, and your CRP decreased from 60 back to 2. It's just awesome. You're doing great. But they have no diagnostic value whatsoever. That's why I told you I doubt it. I doubt, therefore I am. Why not? Because ESR and CRP are high in many diseases. So just because your ESR and CRP are high doesn't mean you have pneumonia. Doesn't mean you have rheumatoid arthritis. It doesn't mean anything. It means there is a problem. Let's go fishing to see which problem do you have. So just because your ESR and CRP are high doesn't mean you have rheumatoid arthritis. They have no diagnostic value whatsoever. I will diagnose you based on your CRP, said no doctor ever. Conditions that will raise the CRP level in your plasma. As I've said, it's non-specific. So inflammation, infection, necrosis, trauma, or as some people might say, trauma, malignancy, allergy, or as some might say, allergia. ¿Cómo estás, amigo? Por favor. I hate myself. ESR and CRP, if they are extremely high, think infection, malignancy, or vasculitis. They are more sensitive and less specific. Why more sensitive? Because they can rule out the acute inflammation. If ESR and CRP are normal, you probably don't have an acute inflammation. This is called ruling out a disease. As you know, the test that has high sensitivity has high negative predictive value, and it can rule out the disease. Cool. Less specific. Why? It couldn't tell which kind of problem is it. The video is not over yet, but I have great news for you. I have 50 hematology cases on my Patreon website. Go to patreon.com/medicosis. They are amazing and they are more difficult than anything that you have seen in your lifetime. Some of them are easy, but many of them are just difficult and you will lose your mind. And this is a good thing because you're learning. Losing your mind right now is better than losing your butt in your test. So just get the cases and make grandma happy. Does CRP have a prognostic value? Yes. Increased CRP level is correlated with increased risk of cardiovascular disease. Oh, really? Yes, indeed. Less than 1, you have low risk. 1 to 3, intermediate risk. More than 3, high risk of cardiovascular disease. But again, as in medicine, the high CRP must correlate with the history, including family history, physical exam, other risk factors of cardiovascular disease, and other lab results. They have to fit the narrative. If you are 21 years old, you don't have any family history of heart disease, you go to the gym every day, you are perfectly healthy. Should I go to the doctor to get my CRP level checked? Shut up. It has to fit with the story. Again, I'm not giving medical advice. Talk to your doctor, but just don't lose your mind because you've heard of something cool over YouTube. ESR versus CRP. ESR increases in inflammation, and so does CRP. This depends on fibrinogen, and fibrinogen's half-life is about 7 days, which means ESR may remain high even after resolution of the inflammation, because 7 days is a lot. Even after curing the inflammation, the fibrinogen is still in the system, so ESR is gonna be high even if you are now fine. However, CRP is better. Why? The half-life is just 7 hours. So CRP rises rapidly and CRP falls rapidly when you remove the inflammation. So after you cure the inflammation, if you want to double check to see if this patient is improving, which test should you do? The CRP. Of course, we do both, but when you see ESR is high, but CRP is improving, it's good news. The mnemonic that I use is that this is C-reactive protein. It's more reactive, it's more flexible. It rises rapidly, it falls rapidly. Quick facts. Patients with obstructive sleep apnea, they have high CRP and interleukin-6. Females who take oral contraceptive pills, they have high CRP level, and they have increased risk of thrombosis and maybe cardiovascular events, especially with smoking. If you're a female, as Dr. Golian said, if you're taking oral contraceptive pills and smoking at the same time, you're asking for a thrombus. This is very important. Don't mix those two together. If a pregnant woman suddenly started having high CRP during pregnancy, it could be a marker of an obstetric complication. Which complication? I have no clue because CRP is very non-specific, remember? Quiz time. Here's a question for you. Let me know the answer in the comments. What's the difference, not between, but among, because they are more than two. I'm very accurate and meticulous. Among C-reactive protein, protein C and C-peptide, are they the same thing or are they different? If they are different, how come? Let me know your opinion in the comments. Thank you guys for watching. Subscribe to YouTube and hit the bell. Go to my Facebook page, and to get all of my notes and 50 hematology cases and counting, go to patreon.com/medicosis and I will send you my Dropbox links. Thanks for watching. Until next time, be safe, stay happy, and study hard.